Hello, my name is Maher Albitar. I am the CMO and CEO of Genomic Testing Cooperative. Today, I'm going to talk about homologous recombination deficiency testing in tumors in general and explain what it means and what the current standards of testing for homologous recombination. First, to explain or to define homologous recombinations, I'm going to explain what happens in this process. So we all know that with our exposure to various toxic materials, with cells dividing, sometimes mistakes happens, and DNA can really be broken, and we see single strand breaks as well as double strand breaks. The single strand breaks is easy; it is corrected because you have the second strand there. So our organisms or our cells are capable of fixing it because of copying what's on the second strand. Barb, in particular, is involved in single strand repair and play a major role. At the same time, Barb is also involved in the double strand breaks. When we have double strand breaks, things are more complicated. And as you can really see here in this slide, on the left side of the slide, the break can be fixed if it is very simple with non-homologous end joining, and this is what you see on the top. But if there is overhanging breaks, this is where there are multiple ways of fixing this break in a principle. So the first one on the left, where, as you can really see, there is no homologous recombination. It is so-called synthesis-dependent strand annealing, and that's what the SDSA stand for. And simply the system or cells can really fix this break by copying it without homologous recombinations and fix this break. Now, on the right side, if this break to be fixed with homologous recombination and forming so-called the holiday junctions, and this is where the recombination takes place, and or double holiday junctions practically is essential for fixing this break. And there can be some exchange in DNA between different DNA fragments in the cells. So this is where the system is dependent significantly on the HRR, or the homologous recombination repair genes. And if there is any defects, mistakes can really happen here. And this is where we end up with homologous recombination deficiency. Now, the genes which are involved in the entire process are numerous. So as you can see, this is a list of the genes which are involved in homologous recombination repair. And in the principle, you get practically all these genes involved in Fanconi anemia, which is a very serious manifestation of deficiencies. And of course, you get the BRCA1, BRCA2, which are involved in the breast cancers. And the list here, as you can really see, very big, but the most common genes involved are BRCA1, BRCA2, BRIP1 or BRIB1. You get the RAD50, RAD51s. These are the most commonly mutated genes in this process. Now, not all these genes are created equal, and some of these genes could be mutated, but you don't really have the phenotype of deficiency. The other things which is extremely important, now we understand it better than ever before, that sometimes you don't have a mutation in any of these genes, but you have deficiency because of epigenetic influence on these genes, which is mainly methylations. So methylation can deactivate any one of these genes without mutations. And now, there are situations where we can really see, even in BRCA1 and BRCA2, we can really see methylations that affect the expression of these genes or causing deficiency of these genes without mutation. And this is very important field that is evolving today. Well, in addition to these genes, which are directly involved in DNA homologous recombination repair, there are other genes. When they are defected, they can really increase sensitivities to homologous recombination deficiencies. So these are the genes which are very important, like the ATM, ATR, the Bloom syndrome genes, the BLM, the CHEK1, CHEK2. These are commonly mutated. And even the TP53 may play a role in this process and can give you a phenotype of homologous recombination deficiencies. Again, as you know, our biology is very complex, and sometimes you need mutations in two genes that they work together and give you the phenotype of deficiencies. And sometimes mutation in multiple genes give you that phenotype, and sometimes methylation as well as mutations can really give you that phenotypes. So practically, the bottom line, looking for mutation alone is good, but not necessarily sufficient for determining if the patient or the tumor has homologous recombination deficiency or not. So the whole purpose of course, the clinical purpose of demonstrating homologous recombination deficiency is the treatment with platinum-based therapy or PARP inhibitors, as you can really see here on the left. So for testing for this, you can really look at mutation in one of these genes, or so-called HRR abnormalities, and you can really look at that as a germline abnormalities as well as in the tumor. So it is very important to understand that deficiency can really arise because of somatic abnormalities. In addition to, it could be arise because of germline, or because of combination of both germline and somatic abnormalities. So you can, as you can really see here on the top, you can really look at the mutation in the genes, but in the middle here, where you can really look at homologous recombination deficiencies by functional assays, which means that practically you put materials in the tube and test for it, and this requires fresh tissue, which is not practical. The most common way and the most reliable way for looking, and practical way for looking at homologous recombination deficiency is to look at the end results which is genomic instability or scarring in the chromosomes that in these cells, in the tumor cells. And they are called scars because they are the results of the deficiency in homologous recombination. And in practice, these scars can be looked at by looking at the loss of heterozygosity or at telomeric allelic imbalance or at so-called large-scale state transitions, which I'm going to talk about in more detail. So practically, this is phenotype, and you always want to look at the phenotype. That's the best really indication whether this patient is going to respond to platinum-based therapy or PARP inhibitors. So this testing or looking for these scars is, as you depicted here on the right, you look for loss of heterozygosity, and this can be either by copy number change. So this is how you lose heterozygosity, or by copy number neutral loss of heterozygosity. And that's where the two chromosomes will have the same copy of DNA. So instead of being one from the father and one from the mother, both of them of the father or the mother, and this is called copy number neutral loss of heterozygosities, or by looking at telomeric allelic imbalance, so you can lose fragments of the end of one of the chromosome, or the large-scale state transitions, and these where you have breaks in actually in less than 10 megabase of DNA and multiple breaks there, and you can really look at that. And again, as I mentioned, the drivers for these abnormalities could be mutation or methylations of genes that can be inherited, as well as can be acquired or somatic. Now, frequently people do testing for germline before doing testing in the tumor. In my opinion, always you should really start testing in the tumor. If you have a mutation, you will see it in the tumors in one of these genes which are involved in the homologous recombination deficiencies. And you can, if you see these mutations, you still need to demonstrate the phenotype, which is the deficiency in the chromosomal, which means that you need to demonstrate the chromosomal scarring and the abnormalities in the chromosomes. But if you don't see any abnormalities or any mutation in the tumor, practically there is no point of looking for mutations by testing the HRR alone without, if you are not looking for methylation. So I always see some people, despite you don't really see evidence of homologous recombination deficiencies or scarring, and you don't see mutation, and there are some clinicians insist on ordering germline testing for HRR, and that doesn't really make sense at all, and it's waste of time and money, in my opinion, testing for that, especially if you are not looking for methylation. So it is crucial to look first in the tumor. And by analyzing the tumor and doing complete profiling of the tumors, you can also have idea about what's happening in other genes. You might find targeted abnormalities that can really help you in making decision how you're going to treat that tumor. So again, currently, homologous recombinations deficiency, at least by FDA, is recommended for breast cancer, ovarian cancer, prostate cancer, and pancreatic cancer. And the drugs currently on the market are listed on the right, in addition to the platinum-based sensitivities for these patients. Now, this is example for what we see in terms of DNA scarring. So this is a diagram for showing the chromosomes. The panel on the left is from a patient with BRCA1 mutation, and the panel on the right is from a breast cancer that does not have deficiencies in any of the genes are involved in homologous recombination. And as you can really see, the line in the middle represents what you're supposed to see in terms of the copy number of the chromosomes. So if you look at the right, you can see the P arm of the chromosome 1, for example, and the Q arm of the chromosome, and in the middle is the centromere. And as you can really see, there is very little gain here on chromosome 8, for example, on the P arm and on the Q arm. And there's very little gain on chromosome 11 and as well as on chromosome 22. Compare that with what you see on the left in a patient with BRCA1 mutations. So as you can really see, there are numerous gain and losses in each chromosomes, and it's practically broken apart, each chromosome broken into multiple pieces. And this is classic, really extreme phenotype that you see in patients with BRCA1 and BRCA2. And for that reason, you can imagine so many abnormalities. These abnormalities are driving the cancer. This is why most of the patients with HRD, they don't need other driver abnormality. And this is why they are most of the time triple negative, and they are driven by the chromosomal abnormalities rather than by other mechanisms like HER2 or other abnormalities. So we need to evaluate these abnormalities. And the way we approach this evaluation or this scarring by using artificial intelligence and machine learning. And this is actually example of what we use for our machine learning, because as you can imagine, I just showed you the extreme. There are some patients in between, and using AI or machine learning that take out the human counting of these abnormalities is, in my opinion, the best way of doing it. And as you can really see here, it gives us for predictions of the presence or absence of homologous recombination very high sensitivities. It is in the range of the 96% sensitivity and 96.8 and 95.2 specificity. It's really very remarkable high sensitivity and specificity for detecting homologous recombinations. And as I mentioned, the algorithm is driven, or our algorithm is driven by considering BRCA1, BRCA2, breast cancer, or ovarian cancer mutant as a gold standard. But sometimes if we have mutations in other double-strand break repair genes like the ATM or the RAD50 or RAD51 or BALB2, the scoring for the algorithm might be different. And as you can really see here, the scoring is high, but completely different from or significantly different from patients who are or tumors that are negative for scarring or for the homologous recombination deficiencies. And I like when it stopped here. And take questions. And thank you very much for your attention.
Una disculpa. Buenas tardes a todos. Les quiero presentar al doctor Albitar. Él nos acompaña de Genomic Testing Cooperative. Él es el CEO y el Chief Medical Officer, CMO, de Genomic Testing Cooperative. Es un laboratorio basado en Irvine, en California. Y vamos a hacer esto un poquito entre español e inglés para poder apoyar con todo, digamos, esta parte de poder dar. He is a part of the academic faculty at the University of California in Camp Davis in Sacramento. He was an outstanding professor at MD Anderson for multiple years. He comes with multiple article publications in peer-reviewed journals and participations in research protocols as well. Él es parte de la unidad académica de la Universidad de California en Camp Davis en Sacramento. Él fue profesor por varios años en MD Anderson, una institución muy reconocida, y aparte cuenta con varias publicaciones y ya se la ha pasado en esta parte académica y haciendo un poquito más relevante toda la parte oncológica. Dr. Albitar, it is my pleasure to have you here with us. So we can go ahead with some questions, if it's okay for you.
Sure.
Okay. So there are around 56 HRR genes. Are there any more that are being discovered in this family that may be helpful in the oncology area?
I am sure there are genes which are involved in HRD, and they are continuously discovered, but most likely they work in combination or in collaboration with other genes for making the overall phenotype of deficiencies. We're always discovering new genes, and I'm sure there are more genes to come. But again, currently most of the phenotypic abnormalities can be considered multigenic abnormalities. And you might have a deficiency in one gene by itself, maybe not adequate for the phenotype of HRD. But if you have two mutations in two different genes or three genes or so on, they might really lead to HRD phenotype.
Perfect. Thank you. I'm going to read one more question. Una resumen rápidamente. Si había más de alrededor de 56 genes de la cadena de la familia HRR, y dice el doctor que sí están habiendo más, hay más que se están identificando poco a poco, que nos van a ayudar a poder tener mejores tratamientos y mejor definición para los pacientes oncológicos. Second question, Dr. Albitar, is PARP inhibitors are becoming important part in treatment for breast, ovarian, prostate, and pancreatic cancers. Do you see any more treatments developing from testing HRD status on these patients?
If I understood your question, I mean, definitely every patient with cancer in the ovarian, lung, and breast and pancreas should be tested. But in my opinion, other types of tumors, including lung, including colon cancers and so on, should also be tested and explore these possibilities. No question about it. Even hematologic diseases, in my opinion, sometimes we see so many genomic abnormalities, and currently we know that cancers, in terms of oncogenesis, there's significant overlapping in the mechanism, and that might have implication on therapy. But definitely all types of tumor should be tested, in my opinion.
Okay, perfect, thank you. La pregunta habla sobre el auge que se ha tenido de los inhibidores PARP, tipo de tratamiento, que sí se han visto en el área de ovario, de mama y de próstata y de páncreas, y que si se pueden utilizar en otras áreas, en otros tipos de cáncer. El doctor dice que sí, que él en su experiencia cree que debería estar en algunos como tipo de pulmón para poder tener este estatus y poder ayudar con este tipo de tratamientos. Entonces, en pocas palabras, está aumentando la utilidad de este marcador HRD para poder conocer para poder tener disponibilidad de este tipo de tratamientos. Okay, Dr. Albitar, I have another question. How is artificial intelligence, AI, and machine learning helping in improving the evaluation of HRD?
Very good question. The abnormalities can be so many abnormalities, and there are some laboratories come up with a scoring system. And the scoring system is based on artificial things. And as a matter of fact, it calculates limited factors in that scoring system, versus machine learning can really take thousands of abnormalities. And this is what we do. Takes not only one or two, and actually it takes more than 15,000 different abnormalities, and put them all together and compare them to what we see in patients with the classic gold standard BRCA1 and BRCA2 abnormalities, and tell you whether you have chromosomal or scarring similar to BRCA1 or BRCA2, or you have or you don't have it like that. And so it is really more accurate, and at the same time, it's less amenable to human mistakes. So it's definitely where this is being applied in medicine more frequently, especially when we are dealing with large data, big data, like what we do with genomic sequencing.
Okay, thank you. La pregunta fue sobre cómo la inteligencia artificial y machine learning es el aprendizaje que se va a mejor, digamos, se cataloga mejor un resultado al tener la ayuda que puede estar sujeta a error humano. Y eso es a lo que todo el mundo nos enfrentamos. Se trata de minimizar, pero siempre está el riesgo de poder tener un mal humano. Y esta parte de inteligencia artificial y machine learning, juntos, en conjunto con el médico, el patólogo, el que realiza la prueba, el bioinformático, y todos en conjunto, un equipo, pueden obtener ese tipo de resultado con una mejor utilidad clínica al tener todas estas variantes consideradas por medio de la inteligencia artificial y machine learning, además de la parte humana. Okay, Dr. Albitar, I have one more question. Will HRD become a main marker for all our oncology patients as the types of cancer become increasing?
As I mentioned, it needs to be done with every cancer profiling. And frankly, this is why I think we integrated HRD into our molecular profiling. If we are looking for any mutations or mutation profiles, HRD should be part of that evaluation. It shouldn't really be as a separate test ordered only on special situation. So it is very important to do it. And as I mentioned, looking for a mutation in genes only, or HRR testing, is inadequate for evaluating HRD. You really need to look at the end results or the DNA scarring or chromosomal abnormalities. And again, it needs to be done on all types of cancer, absolutely.
Okay, thank you. Okay, la pregunta que le hicimos fue que si el marcador de HRD podría ser un marcador que se haga un marcador principal para los pacientes que tienen cáncer. Y él coincide con que se debe pedir, está con más tipos de cáncer. Entonces se tiene la tendencia ahorita de volverse un marcador muy importante a futuro por todos los tipos de cáncer en los cuales se va a poder aplicar y con los cuales vamos a poder tener información adicional para un mejor tratamiento para los pacientes. Ok, bueno, les agradezco muchísimo. El doctor Albitar, Dr. Albitar, would you have any other comment as right now as all the questions I have? Would you have something to add up for this presentation?
No, but I think a key in today's precision medicine and precision oncology is to do molecular profiling. I do believe that every patient with cancer should have the right, or it's actually necessary, extremely necessary, to do complete molecular profiling on these cancer to understand that driver that drives that cancer. And most of the current assays, or our assays at least, can evaluate the patients as well as, which means the host, as well as the cancer. We all know in today's standards, not two cancers are the same, and not two patients with the same cancer are the same. So if you take lung cancer or ovarian or breast cancers, each breast cancer is different from the next, and each patient who have even the same cancer is different from the next patient with cancer. So it's very important actually, and it is very exciting time that we can do these things and we can do precision medicine. And I think precision medicine should be available for every patient with cancer, not for those who just a few who go to academic center.
Totally agree with you. I believe also as well, if we have a big picture of the cancer that's attacking the patient, instead of start with little parts and parts, should put all together. And with all these markers together, has becoming now a tendency with now TMB, MSI, PDL1, HRD are becoming part of an integral and whole view of the tumor and the patient as one in one whole result of these genomic profiles. So we have this available at GTC, Genomic Testing Cooperative, and we're very excited about all the new markers that are coming and how all these give us a nice clinical utility for the benefit of our patients. Voy a hacer una pequeña nada más narrativa, un poco fue algo largo esto, pero en sí lo que el doctor quiere hacer hincapié es en digamos la parte que tenemos tener más información de diferentes marcadores para hacer todos en una sola prueba de tumor genómico, digamos un panel genómico que va a englobar diferentes marcadores, incluido el HRD, que ahorita acabamos de ver la utilidad clínica que tiene, pero adicional también estamos agregando marcadores como TMB, Tumor Mutation Burden, el MSI, que es inestabilidad microsatelital, MSI, PDL1, expresión de PDL1, que también todo esto nos ayuda en el área de inmunoterapia, y todo hace una sola prueba, nos puede dar todo este tipo de información para de una vez tratar al paciente con la mayor información posible para un mejor desenlace para el paciente. Dr. Albitar, it is my pleasure to have you over here with us. It was a really nice chat that we had with you, very nice presentation. We're very happy and excited to keep working with you and to explore new possibilities of different options for our patients. And we know that we count with all the support from Genomic Testing Cooperative, yourself and your wonderful team that has been helping us for now quite some good time. So we're looking forward to keep working with you. and to expand the use of this type of genomic testing to all our patients in Mexico and Latin America. I thank you so much for being present here.
Thank you very much. Thank you for giving us the opportunity to talk to you and to your groups.
My pleasure. It is my pleasure, really. Okay, es una pequeña despedida del doctor. El doctor nos hizo el favor de acompañarnos para podernos dar la plática de HRD, que ha sido una gran plática para poder entender estos nuevos marcadores emergentes y la utilidad clínica que pueden tener hacia nuestros pacientes. Agradecemos a todos su presencia, que nos hayan prestado un poco de su tiempo para poder entender ese tipo de nuevos marcadores, para que al final tenga un beneficio hacia sus pacientes. Me pongo a la orden también, doctor Salvador Cardona, y para apoyar también con todas las pruebas que pudieran estar. Estamos disponibles, Millennial Labs, y en conjunto con GTC, Genomic Testing Cooperative, para poder ayudarles a solucionar cualquier necesidad que tengan de pruebas diagnósticas. Les agradezco mucho, que tengan un muy bonito resto del día. Hasta luego. Thanks so much, Dr. Albitar. Have a great day.